There are moments in life that change everything you thought you knew about your profession, your colleagues, and yourself. Moments when you realize that staying silent could cost someone their life, but speaking up could cost you your career. I am about to tell you about the night that tested every ounce of courage I had, the night I discovered something on an X-ray that a respected surgeon had completely missed, and the night I understood that sometimes the most dangerous thing in a hospital is not the disease, but the arrogance of those who refuse to listen. This is my story, and I need you to hear every single word of it, because what happened that night should never happen to anyone, anywhere. My name is Laura Brennan, and I have been working as an emergency room nurse at St. Catherine Medical Center in downtown Chicago for the past 8 years. When I first started my career, I was 23 years old, fresh out of nursing school, and absolutely terrified of making mistakes. The hospital where I work is massive, one of those intimidating buildings with endless corridors, fluorescent lights that never turn off, and a hierarchy so rigid it feels like a military organization. At the top of that hierarchy, far above nurses like me, are the attending physicians and surgeons, people whose word is considered law, people you do not question unless you want to be labeled as difficult or insubordinate. I learned that lesson very quickly during my first year when I dared to suggest a different medication dosage to a senior doctor and was promptly told to stay in my lane. From that moment on, I kept my head down, did my job efficiently, and tried not to make waves. But there was always something inside me, a small voice that refused to be completely silenced, a voice that whispered that good nursing was not just about following orders, it was about truly seeing patients, noticing what others missed, and trusting your instincts even when everyone else dismissed them. That voice stayed quiet for years, until the night everything changed. The night I met a patient named David Chen, and the night I came face to face with the most arrogant surgeon I had ever encountered, Dr. Gregory Morrison. If this story has already grabbed your attention, go ahead and subscribe to the channel right now, because what comes next is going to surprise you even more. And I want to know, where are you watching this from? Drop a comment and let me know your city or country. It is incredible to connect with people from all over the world who understand what it means to face impossible situations like this. Dr. Gregory Morrison was a legend at St. Catherine Medical Center, but not necessarily the good kind of legend. He was 52 years old, chief of general surgery, and had a reputation that preceded him wherever he went in the hospital. On paper, his credentials were impeccable. Top of his class at Johns Hopkins, fellowships at prestigious institutions, published research in major medical journals, and a success rate in complex surgeries that was genuinely impressive. Patients loved him because he exuded confidence, that commanding presence that made you believe everything would be fine if he was the one holding the scalpel. But those of us who worked alongside him, especially the nurses and residents, knew a different side of Dr. Morrison. He was condescending, dismissive, and had a particular talent for making people feel small with just a few words. He rarely learned the names of nurses, referring to us as the blonde one or the short one when he needed something. He had a habit of interrupting anyone who tried to offer input during patient evaluations, rolling his eyes dramatically whenever a resident suggested a diagnosis he had not thought of first. I had witnessed him berate a young intern so harshly for a minor mistake that the poor guy left the hospital and never came back. The worst part was that the hospital administration adored Dr. Morrison because he brought in revenue. His surgeries were high profile, his patients were often wealthy, and complaints about his behavior were quietly swept under the rug with excuses about brilliant surgeons being allowed certain eccentricities. We all knew that confronting Dr. Morrison was career suicide, so most of us just endured his attitude and tried to avoid working his shifts whenever possible. Thank you for staying with me this far. It shows that you feel the same thing I felt when I lived through all of this. So go ahead and subscribe and turn on notifications, because what comes next changes everything. It was a Thursday night in late October, one of those cold Chicago evenings when the wind cuts through your jacket and the city feels darker than usual. I was working the night shift in the emergency department, and it had been relatively quiet until around 11:30 when the ambulance radios crackled to life. A 47-year-old male patient was being brought in with severe abdominal pain, nausea, and vomiting. When the paramedics wheeled him through the doors, I could immediately see he was in genuine distress. His name was David Chen, a restaurant owner from the South Side, and he was clutching his abdomen with both hands, his face twisted in agony, sweat pouring down his forehead despite the cold outside. His wife was following closely behind, terrified, and holding their teenage daughter's hand. I helped transfer Mr. Chen to a gurney and began taking his vitals while asking about his symptoms. His blood pressure was elevated, heart rate was racing at 110 beats per minute, and he was struggling to find a comfortable position. He told me the pain had started suddenly about 3 hours ago, right after dinner, and it had been getting progressively worse. The pain was localized to the right lower abdomen, sharp and constant, and he said it felt like something was tearing him apart from the inside. I documented everything carefully and requested an X-ray X-ray and blood work immediately. While I was setting up an IV line, Dr. Morrison walked into the emergency bay. He had been called in because the on-call surgeon was tied up in the operating room with another case, and Morrison lived close to the hospital, so he often took overflow emergency consults. He approached Mr. Chen's bed with his usual confident stride, barely glancing at the patient before picking up the chart I had just updated. Dr. Morrison spent maybe 90 seconds looking at the preliminary notes before he set the chart down and turned to Mr. Chen with what I can only describe as theatrical skepticism. He asked a few perfunctory questions, pressed on the patient's abdomen in a cursory examination that made Mr. Chen cry out in pain, and then stepped back with his arms crossed. What happened next still makes my blood boil when I think about it. Dr. Morrison looked at Mr. Chen and said, in a voice loud enough for everyone in the emergency bay to hear, that it was probably just gas, maybe some indigestion from eating too much greasy food, and that some people have a very low pain tolerance. He actually used those exact words, very low pain tolerance. Mr. Chen tried to protest, saying this was different from anything he had ever felt before, that something was seriously wrong. But Dr. Morrison cut him off with a dismissive wave of his hand. He turned to me and the other nurse on duty, and made a comment about how some men cannot handle even minor discomfort, how they come to the emergency room for things that a simple antacid could fix. A few of the residents who were nearby laughed nervously, unsure if they were supposed to find it funny or not. Mr. Chen's wife looked humiliated and angry, but she did not say anything because, like most people, she assumed that the doctor must know what he is talking about. I felt my stomach drop. I had seen enough abdominal emergencies to know that what Mr. Chen was experiencing did not look like gas or indigestion. His presentation was concerning, the sudden onset, the localized pain, the elevated vitals, but Dr. Morrison had already made his pronouncement, and questioning him in front of everyone would be seen as insubordination, so I stayed silent, and I have regretted that silence every day since. Then Dr. Morrison ordered a basic painkiller and told Mr. Chen to go home, rest, and take some over-the-counter medication for gas relief. He said if the pain persisted for more than 24 hours, he could come back for a follow-up, but he was confident it was nothing serious. Then he walked away to see another patient, leaving me standing there with Mr. Chen, who was now trying to sit up and looked even worse than when he had arrived. His wife asked me directly if I thought her husband should really go home, and I could see the hope in her eyes that I would contradict the doctor's assessment. But what could I say? I was not a physician. I could not override Dr. Morrison's orders, and if I expressed doubt about his diagnosis, I could face serious consequences. So I did what I was trained to do. I smiled reassuringly, told her to follow the doctor's instructions, and said that if things got worse, they should come back immediately. As they were preparing to leave, I helped Mr. Chen into a wheelchair because he was too weak to walk on his own. That was when I noticed something that made my nursing instincts scream. He was developing a cold sweat, his skin was clammy and pale, and his blood pressure, which I rechecked quickly, had dropped significantly in just the 20 minutes since he had arrived. These were not symptoms of gas or indigestion. These were signs of something much more serious, possibly a surgical emergency. I watched as Mr. Chen was wheeled toward the exit, and I felt a growing sense of dread that I could not shake. Something was very, very wrong, and I could not let him leave without being absolutely certain we had not missed something critical. Now I want to hear from you. Where are you watching this story from? Write it in the comments. It is incredible to see people from so many places following stories like this. I made a decision in that moment that could have ended my career, but I knew I would never forgive myself if I did nothing. After Mr. Chen and his family left the emergency bay, I told the charge nurse I needed to check something in radiology, and I went directly to the imaging department. The X-ray that had been taken of Mr. Chen's abdomen was already processed and uploaded to the system. Technically, I was not supposed to be reviewing images without a physician's order or supervision, but I had worked in emergency medicine long enough to recognize basic abnormalities on X-rays, and I needed to see for myself if there was something we had missed. I pulled up the images on the computer screen, and at first glance everything looked relatively normal. The standard views of the abdomen, intestines, organs in their proper positions. But then I noticed something in the lower right quadrant that did not belong there. It was subtle, easy to miss if you were not looking carefully. But once I saw it, I could not unsee it. There was a small, dense, irregularly shaped object lodged near the intestinal wall, something that should absolutely not be there. I zoomed in on the image, adjusted the contrast, and felt my heart start to race. It looked like a foreign object, possibly a sharp fragment of something, positioned dangerously close to what appeared to be the appendix and surrounding tissue. If that object had perforated the intestinal wall or caused inflammation, Mr. Chen could be hours away from sepsis, internal bleeding, or worse. I felt panic rising in my chest. Dr. Morrison had not even looked at these images before dismissing the patient. He had made his diagnosis based on a cursory physical exam and his own arrogance, and now a man's life was in danger because of it. I printed out the X-ray images and practically ran back to the emergency department, looking for Dr. Morrison. I found him in the physician's lounge, casually drinking coffee and chatting with one of the cardiologists about a golf tournament. When I approached him, holding the printed X-rays, he looked annoyed that I was interrupting his break. I took a deep breath and told him as professionally as I could that I had reviewed Mr. Chen's abdominal X-rays and found something concerning that I thought he should look at immediately. Dr. Morrison sighed heavily, set down his coffee, and took the images from my hands with obvious irritation. He glanced at them for maybe 10 seconds before handing them back to me and saying he did not see anything significant, just normal bowel gas patterns and shadows. I pointed directly at the foreign object I had identified and said it looked like a potentially perforating foreign body near the appendix. He looked at me with barely concealed contempt and said that nurses should not be interpreting X-rays because they do not have the training to understand what they are seeing. He told me I was looking at an artifact or a shadow, nothing more, and that I was wasting his time with hysteria over a patient who clearly had gas. I insisted, my voice shaking now, that Mr. Chen's vital signs were deteriorating, that his presentation was consistent with a surgical emergency, and that we needed to call him back immediately. That was when Dr. Morrison lost his temper. He told me in front of several other staff members that I was overstepping my role, that I needed to remember I was a nurse and not a radiologist or a surgeon, and that if I continued to question his medical judgment, he would file a formal complaint with the nursing administration. The room went silent. Everyone was staring at me, waiting to see what I would do next. I had two choices: back down and let it go, or push forward and risk everything. Enti indignans. I chose to risk everything. I looked Dr. Morrison directly in the eyes and said that I was formally requesting a second opinion from another attending physician because I believed there was a serious diagnostic error that could result in patient harm. The words came out more confidently than I felt inside. Dr. Morrison's face turned red, and I could see the fury in his eyes. But hospital protocol was on my side. Any staff member, including nurses, has the right to request a second opinion if they believe a patient is in danger, and refusing that request could open the hospital to massive liability. Morrison knew this, and he also knew that if he refused, and something happened to Mr. Chen, his career would be over. So he agreed, but not without making it clear that I would face consequences for this insubordination. He paged Dr. Elizabeth Reeves, the head of emergency medicine, who was still in the hospital finishing up paperwork from her shift. When Dr. Reeves arrived and I explained the situation, showing her the X-rays and describing Mr. Chen's deteriorating condition, her expression changed immediately. She studied the images carefully, much more carefully than Morrison had, and then looked up with concern. She said it absolutely looked like a foreign body, possibly a bone fragment or metal object, and given the patient's symptoms and vital signs, this was a potential surgical emergency. She immediately ordered the on-call surgical team to locate Mr. Chen and bring him back to the hospital for an emergency CT scan and possible exploratory surgery. Dr. Morrison stood there, speechless, as the reality of his mistake began to sink in. Within 30 minutes, Mr. Chen was back in the emergency department, now in even worse condition than before. The CT scan confirmed what I had seen. A sharp chicken bone fragment had perforated his intestinal wall and was causing localized peritonitis that was rapidly progressing toward sepsis. He needed emergency surgery immediately. Mr. Chen was rushed into surgery within the hour, and the operation lasted nearly 4 hours. The surgical team removed the perforating bone fragment, repaired the intestinal damage, and cleaned out the infection that had already begun spreading through his abdominal cavity. The surgeon who performed the procedure told me later that if Mr. Chen had gone home as Dr. Morrison had instructed, he would have likely died within 12 to 24 hours from septic shock and organ failure. That single chicken bone, probably swallowed accidentally during dinner, and sharp enough to pierce through tissue, had nearly killed him, and it would have if I had not trusted my instincts and fought to have him reevaluated. Mr. Chen spent 10 days in the hospital recovering from the surgery and the infection, but he survived, and his family was incredibly grateful. His wife came to find me during his recovery and cried as she thanked me for saving her husband's life, for not giving up when the doctor had dismissed him. That moment meant more to me than any award or recognition ever could. As for Dr. Morrison, the consequences were swift and severe. The hospital administration could not ignore such a blatant case of medical negligence, especially when there was clear documentation of his dismissive behavior and refusal to properly evaluate diagnostic imaging. He was suspended pending an internal investigation, and I was asked to provide a detailed written statement about everything that had happened that night. Several other nurses came forward forward with their own stories of Morrison's arrogance and dismissive behavior toward patients and staff. Within 3 months, Dr. Morrison was quietly asked to resign from his position as chief of surgery. The hospital framed it as a mutual decision, but everyone knew what had really happened. That night changed my entire perspective on what it means to be a nurse and what courage really looks like in healthcare. I realized that staying silent to protect my career was not just cowardice. It was a betrayal of every patient who trusted me to be their advocate. I also learned that the most dangerous thing in a hospital is not always the disease or the injury. Sometimes it is the ego and arrogance of those who refuse to listen, who believe their status makes them infallible, and who forget that medicine is a team effort where every voice matters. After the incident with Dr. Morrison, I became much more vocal about patient safety concerns, and I worked with hospital administration to implement new protocols that protect staff members who raise concerns about potential diagnostic errors. I also started mentoring younger nurses, teaching them that their observations and instincts are valuable, that they should never be afraid to speak up when something does not feel right, even if it means challenging someone more senior. Mr. Chen made a full recovery and went back to running his restaurant. He still sends me holiday cards every year with photos of his family, reminding me why I do this job, why every battle is worth fighting, and why trusting yourself is sometimes the most important skill a nurse can have. Looking back, I do not regret a single moment of that night. Not the fear, not the confrontation, not the risk to my career. Because at the end of the day, I helped save a life that was about to be lost to arrogance and negligence. And that is what nursing is really about. And that was the story of how a courageous decision and trusting my own professional judgment saved a life that was being neglected by pure medical arrogance. Now I want to know your opinion. Have you ever witnessed or heard about situations where healthcare professionals dismissed serious symptoms? How do you think hospitals should handle cases of medical negligence? Leave your opinion in the comments. This is very important to me and to our entire community. If you made it this far and this story touched you in some way, do not forget to subscribe to the channel and turn on notifications so you do not miss the next real stories of nurses who face ethical dilemmas and impossible situations in their daily hospital work. And go ahead and watch the next recommended video. I am sure you will be even more surprised by what is coming. Your presence here makes all the difference.